43 years ago by Dr. Romer Reed. And he made a comment to me. He took me under his wing as offered to be a mentor of mine. And we were walking through his office and he said, you know what, Gary, remember, this is 1980. Let's put it in a 1980 perspective. He said, Gary, you know what? Most dentists are file cabinet millionaires. File cabinet millionaires. Now, I must have had a look of bewilderment on my face. Remember, I was very young, just getting started in this profession. And honest to God, I didn't know what he meant. And I must have had a look, and he said, Gary, let me take a minute and explain that. I said, please do, Dr. Reed, because I didn't know what he meant. And go back to 1980 and realize that we had paper charts. Remember those charts, Aaron? You don't remember those. Those are before your time.
I do remember it. Even now I see some doctors having paper charts. I don't like to see it, but I do see it.
Yeah. But back then we only had paper charts. And typically those went in storage cabinets, open faced, bookshelves where they went, the active ones, the ones that were coming in regularly, but the ones that, we hadn't seen in a while went into a file cabinet. And they kept those for a period of time. They had to keep them for a period of time for legal reasons, for records reasons. They couldn't just dispose of them. What Dr. Reed meant by that is if dentists could just get their existing patients to accept treatment that was recommended, their practice would quite literally thrive if they could just get their existing patients to accept recommended treatment. And that's what he meant by file cabinet millionaires. And he's absolutely right. Back in the day, we used to do unscheduled treatment plan reports, and you can still do those. And if you've been in practice for a period of time, it's staggering to see how much dentistry you've been presented that remains to be done. It will be over 7 digits. It will be millions of dollars if you've been in practice a period of time. Now, let's break this down a little bit. For symptomatic treatment, the patient that comes in with a toothache, and it's kept them awake for 3 nights in a row. This cheek is full of swollen out, beyond the confines of their cheek, and tears are rolling down their cheek. And you recommend, well, let's go to Dr. Luba. You recommend root canal therapy to take care of that toothache. If you don't have 100% case acceptance on that case, you might want to think about another career. I'm being humorous to lighten up the topic, but Nair, would you agree with me on that? If the patient's in pain and they're in your office and you can help them with whatever that is, you can help them with palliative treatment or perhaps an extraction, perhaps root canal therapy. If they're in pain and you can help them, if you don't get 100% case acceptance on that one, then something might be wrong.
I agree. I think those are what we call emergency patients, right? So anytime an emergency patient comes in, they want to come in right now because they're in pain. Right now, meaning literally, I'll drop everything else. I'll get into my car and I'll come here right now.
It is their number one driving force. It supersedes everything else on their list.
Exactly. Right? It supersedes even a wedding they might have that evening.
Everything. This now becomes a number one priority.
Yes.
In a way, I'll say something in a humorous vein. If everybody could show up in pain, that would not be bad, right? We don't wish that. We don't wish that at all.
If they're taking care of their oral health, then of course they don't have to come in pain. Yeah.
We sure have motivation, when the patient is in pain. So I'm not talking about those. Now let's talk about asymptomatic treatment recommendation. This, in other words, they have a need, but it doesn't hurt.
Right.
It doesn't hurt. So a common one that we still see today is the patient has old amalgam fillings that clearly are breaking down. You can tell by visual inspection. You can tell by radiographic inspection. You can tell by photographic inspection. Take pictures and you can see. However, it doesn't hurt. It doesn't hurt. And again, I'm not suggesting we remove all amalgam fillings. I'm talking about where you can see that those fillings are eroding and decaying, and they should be replaced for good clinical reasons. But because it doesn't hurt, the patient might say, well, doc, if it doesn't hurt, I'll wait till it does hurt. What should be your case acceptance on asymptomatic treatment plans? This is something that will benefit the patient, but it doesn't hurt. So we benchmarked this, and what we shoot for, with our clients is we look for, and I'd love to say 100%, but it's not going to be 100% of that. We look for 70 to 80%, 70 to 80, somewhere in that range, for case acceptance for asymptomatic general dentistry treatment plans, asymptomatic general dentistry. 70 to 80% is your goal. Now let's talk about a third type of treatment plan. This would be for ideal care, optimum care, comprehensive care. Perhaps you might use the term elective care. This is something that they could benefit from, but it isn't needed. It isn't needed. What is a good case acceptance? And what I'm doing here is I'm beginning with the end in mind, Aaron. The old, concept, habit number 2 from Stephen Covey.
Yes.
If we don't have a target to shoot for, then any result is okay. We have to have a target to shoot for. So the target for symptomatic general dentistry when they're in pain is 100%. The target for asymptomatic treatment plans is 70 to 80%. Now let's talk about optimal, ideal, comprehensive, elective treatment plan. I'm going to use an analogy here, Naren, for our listeners. I happen to enjoy baseball. I grew up in a baseball family. Happen to enjoy baseball. I enjoy baseball statistics. And if a baseball player who retires had a lifetime batting average in the 300s, let's say it was 360 lifetime batting average. Do you know what kind of label might be put on that baseball player, Aaron?
Hall of Famer.
A Hall of Famer. They will make the Hall of Fame. And if we break that down, if they have a batting average of 360, that means they got a hit 36% of the time.
Right.
That means, out of
100.
10 at bats, or out of 100 at bats, they got a hit 36% of the time. Now, if you look at it the other way, they didn't get a hit 64% of the time. And yet that person would be called a Hall of Famer. If you've got a batting average, lifetime batting average in the 300s, they're called. So I want all of our, I would agree, Naren, all of our listeners are Hall of Famer dentists, aren't they?
They are.
Yeah, they are. They're Hall, because, they're committing extra effort to benefit their patients. So I'd like to think that all of you as listeners are Hall of Famers. So if you want to be a Hall of Famer, we want a case acceptance for ideal, comprehensive care to be between 30 and 40%, 30 and 40%. The higher, the better, but between 30 and 40%. Now you have something to shoot for.